So I would like to thank the organizers for this kind introduction and for asking me to speak this year. I have been asked to cover the year in the thyroid. These are my conflicts of interest. And essentially, when I looked or did a PubMed search for the number of thyroid publications over the last year, there were 11,526. I have tried to cover the time period between April 23 and April 24. And of course, there's only a number of papers and very few actually I can highlight in a 25-minute session. I will admit that there's been an inherent bias of journals that I read regularly and areas of thyroidology I'm particularly interested in. But what I've tried to do is find papers that answer clinical questions that are often asked to me in my practice. So there are 6 main sections to this talk, covering hypo and hyperthyroidism, mild thyroid dysfunction, pregnancy, and then thyroid nodules and cancer. So if you move to the first section, this is on hypothyroidism, and I would like to highlight 3 papers. One on appropriateness of levothyroxine prescription, one of the effects of levothyroxine on hunger and food intake, and then looking at potential effects of polymorphisms in the DIO2 and MCT10 gene and symptoms associated in patients on levothyroxine. So this first study here looked at appropriateness of levothyroxine prescription. It was a retrospective chart review multicenter study performed in the United States and included 977 patients who were started with on a first prescription of levothyroxine between 2007 and 2020. And essentially, these were all rated as either appropriate, indeterminate, or non-evidence-based prescriptions. So the appropriate prescriptions were all clinically supported, but so non-evidence-based ones were where levothyroxine was started in older people over 65 where serum TSH didn't rise above 10, and particularly those who did not have symptoms, or where subclinical hypothyroidism was not confirmed either biochemically or again was unassociated with symptoms. There were a few sort of indeterminate indications where I think this is what we all find in our practice. What do we do with patients who are older than 65, who have symptoms but only have a mildly raised serum TSH, or in younger patients who don't have symptoms? So when this was evaluated by the panel of experts that looked at this, only about 31% of the prescriptions were appropriate. Importantly, the median TSH of those patients who were started on levothyroxine was 7.1 millunits per liter, so not a particularly raised serum TSH. And even more importantly, only 56% of these patients 56% of these patients did not have symptoms. The most important symptom that was reported was fatigue. You can see that in 54% of these patients, there was a non-evidence-based prescription. And this was more common in female patients and when treatment was started by primary care physicians. So the conclusion of this paper was that there still is a high proportion of levothyroxine prescription that is not really evidence-based, and this of course places a significant burden on patients as well as on increased healthcare costs. And what they significantly urge in this paper is that in some of these patients we may have to start deprescribing. This next study I want to highlight in this section is on the effects of levothyroxine therapy on hunger and food intake. So this was a small study, but very interesting in my opinion, a prospective cohort study performed in Denmark. There were 18 newly diagnosed patients who had proper hypothyroidism with a serum TSH greater than 10 and 18 age and sex matched controls. So patients were evaluated at diagnosis where their mean serum TSH was 46.9. They were then re-evaluated when the serum TSH had come under control and the mean was 1.2 millunits per liter. And then again at 6 months where you can see that all these patients were adequately treated. And they were evaluated with regards to their body weight and body composition, but also for hunger, ad libitum food intake, and resting energy expenditure. So all patients were evaluated at 3 visits. And so the first thing to note from this study here is that you can see that the fat mass, despite adequate treatment of levothyroxine, didn't actually change in patients once their serum TSH had been brought under control. And indeed, that is what we often see in clinical practice. Their fat-free mass decreased, but not the fat mass. The resting energy expenditure increased significantly with levothyroxine replacement, and this constituted about 10% of the resting energy expenditure increase, and this was highly significant, and this was true both at the time of control of hypothyroidism as well as at 6 months. But what you can see, and this is really important, I think, for patients, is that their hunger increased very significantly. And I think it is therefore, and what the conclusion of this paper is, that it may be that the increased hunger that you get with levothyroxine therapy results in what we see, that there's often not a significant reduction in fat mass, and that this may actually reduce the anticipated weight loss. The ad libitum food intake was not different between the different visits that patients took place in. And then this is a paper looking at what, again, I get fairly regularly in my practice, patients who say that they've had a genetic test where polymorphism has been found either in the deiodinase 2 gene or in the MCT10 gene, and that is why they are not responding well to levothyroxine. So this was a very large population-based cross-sectional study based on the UK Biobank. You can see nearly 19,000 levothyroxine treated patients and then 360,000 controls. The SNPs that were considered were 3 SNPs in the DIO2 gene and 1 SNP in the MCT10 gene that's previously been associated with local tissue hypothyroidism. So the first thing to notice was that patients who were on levothyroxine when compared to controls had significantly more symptoms, and in particular symptoms of more depressive symptoms, and particular symptoms that were noted were symptoms of tiredness and decreased well-being. But importantly, when the different polymorphisms were looked at, the odds ratio in patients with the polymorphisms either in the levothyroxine treated or the controls was not different. You can see here none of these forest plots show a significant result. And similar results were really seen when they looked at effects on cognition as well as on cardiovascular risk factors. So again, when compared with controls, patients who were treated with levothyroxine were significantly more likely to have worse cognition. But again, when that was then subdivided, depending on the different polymorphisms that patients had, there was no difference in levothyroxine treated patients when compared with controls. When looking at cardiovascular risk factors, looking at BMI and plasma HbA1c, again, this was higher in patients who were treated with levothyroxine compared with controls, but again, the different SNPs did not seem to amplify this or have a significant effect. So the conclusion, therefore, is that carrying the risk allele of these four SNPs does not amplify the symptoms associated with levothyroxine when compared with controls, and so no gene treatment interaction has been found in these polymorphisms. So to conclude the section on hypothyroidism, I've shown a paper that has shown a very high proportion of levothyroxine prescription not being evidence-based and inappropriate, and that deprescribing in a number of these people may be indicated. Levothyroxine therapy in hypothyroid women increases resting energy expenditure and hunger, and this may in part explain why there is a lack of reduction of fat mass, and there has been no evidence of an interaction between different polymorphisms in the DIO2 and MCT10 gene when patients are started on levothyroxine. I have 4 papers that I would like to highlight in the hyperthyroidism section, one on incidence of Graves' disease, one looking at incident hyperthyroidism in patients with atrial fibrillation, some real-life data on outcomes in patients treated for amiodarone-induced thyrotoxicosis, as well as on neuropsychological symptoms in Graves' disease. So the first one was a large study that was published in the Lancet. So this is a population-based study, again, based on the UK CPRD database. You can see that this included more than 22 million people that were followed up over between 2000 and 2019, and of whom nearly 1 million had autoimmune diseases that were diagnosed during that period. 63.9% were female with a mean age of 54 years. And so the incidence of all autoimmune diseases increased with an incidence risk ratio of 1.04. But what was particularly noted was a large increase in the incidence of Graves' disease, and that is highlighted here. And what was also shown was that different autoimmune diseases were commonly associated with each other. Again, this is not particularly surprising, we already knew this, but importantly what this paper highlighted was that patients who were in a lower socioeconomic quintile, so the higher the quintile, the lower their socioeconomic status, were significantly more likely to develop Graves' disease. So clear evidence here that the incidence of Graves' disease has indeed been increasing. Then we all know the link between hyperthyroidism and atrial fibrillation, but this was an interesting retrospective cross-sectional cohort study that was done in Taiwan, looking at just over 8,500 patients aged over 18 who had atrial fibrillation but did not have hyperthyroidism at diagnosis. They were followed up for a mean period of just under 50 months, and 647 of these patients developed hyperthyroidism. And what this paper nicely did was identify risk factors that were associated with an increased risk of someone who has atrial fibrillation, but no evidence of hyperthyroidism subsequently developing hyperthyroidism. And you can see that being female, being older, having diabetes, hypertension, end-stage renal failure, congestive heart failure, and a higher CHA2DS2 score were associated with an increased risk of developing hyperthyroidism. And what they did really here was design a scale where you can see that the higher the score on the scale, the higher the risk is that these patients do develop hyperthyroidism. And then moving on to this study from Italy, which was a single-center cohort study looking at patients with amiodarone-induced thyrotoxicosis. It included 331 patients, and the majority of them, 77%, had type 2 amiodarone-induced thyrotoxicosis, with a smaller number in the type 1 or in the mixed group. And they were considered by the authors to either have appropriate or non-appropriate therapies. And then what was determined in outcomes was the effects on cardiovascular event and hospitalizations. And you can see that only 34.5% of these patients in their first approach to amiodarone-induced thyrotoxicosis had appropriate therapy for their amiodarone-induced thyrotoxicosis type. So the patients that received an appropriate dosage, either optical medical therapy if they had type 1 or right dose combination therapy if they had type 2, was only 34.5%. And you can see that the majority of these patients either were not started on treatment, were started on too low a dosage of treatment, or were started on therapy. And then when they looked at outcomes, you can see that those patients, unsurprisingly, those patients who were not appropriately treated had a significantly higher risk of having cardiovascular events, hospitalizations, and requiring urgent thyroidectomy. And that is what this nice figure here also illustrates. So the patients without adverse outcomes, so all those patients who had optical medical therapy or the right dose of combination therapy, the vast majority of them had no adverse outcomes. And that was similar in those patients who were on either too low a dose of therapy, either single therapy or combination therapy. But you can see that those patients who were started on the wrong therapy or did not receive therapy at all were much more likely to have adverse outcomes. And the authors of this paper therefore urge that the early choice of the right drugs and prompt start of them will reduce cardiovascular events, hospitalizations, as well as the need for urgent thyroidectomy. And then the final paper in this section looked at neuropsychological symptoms in Graves' disease. So this was a prospective longitudinal case control study performed in Sweden, which included 64 premenopausal females with Graves' disease and 64 controls. And they were all assessed twice, once during their thyrotoxic state and once after the treatment was completed. And the measurements that were undertaken were a mental fatigue scale, a depression and anxiety scale, and neuropsychological tests. And this graph here illustrates, I apologize for this. This graph here illustrates what happens. So in patients in the Graves' hyperthyroid state, when you looked at the mental fatigue scale, so mental fatigue scale, anyone who's on this side of the right red line has mental fatigue, and anyone who's above the black line has depression. You can see a significant clustering of patients with Graves' hyperthyroidism in this section, and this was still present after 15 months of treatment, whereas when you looked at controls, this was not present either at diagnosis or after 15 months. And so looking at the mental fatigue score, what this shows here when compared with controls, how indeed this is significantly higher at baseline, but stays raised after 15 months, and similarly for anxiety and depression scales. So residual depression in Graves' disease after treatment was about 15% and mental fatigue 38%. So they are common in patients with Graves' disease and they may persist after treatment, and therefore I think it's important that we provide ongoing support in work and study environments, as well as attention to mental health of these patients. And again, just to summarize the section on hyperthyroidism, what I've highlighted is that the incidence of Graves' disease has increased significantly over the last 20 years, and that there are specific risk factors in patients who have atrial fibrillation, which will predispose them to develop hyperthyroidism. The initial choice of treatment for amiodarone-induced thyrotoxicosis is often inappropriate, and this affects their outcomes. And mental fatigue and emotional distress is common in patients with Graves' disease and may persist after treatment. The third section, I only have time to highlight one paper, and this looked at mild thyroid dysfunction, and in particular the recovery of thyroid function in subclinical hypothyroidism. So this was a 6-year prospective cohort study in 2 areas of China between 2013 and 2019. This included 1,190 patients. About half of them were selenium adequate and half of them were selenium deficient. Selenium deficient patients were younger, had a higher BMI and higher alcohol intake. And to me, at least a little bit surprisingly, was that subclinical hypothyroidism was actually much more likely to recover in patients who were selenium deficient when compared to those who were selenium adequate. And then a further analysis of this paper looked at whether, depending on a number of factors, i.e. where they lived, their gender, their age, and their BMI, so this is a multivariable analysis, what was analyzed was whether these factors influenced recovery of thyroid function. And so patients who were female and older were less likely to recover, and that is also illustrated in this graph here. You can see that certainly before the age of 51, patients are much less likely to recover, and in men this takes until about 73 years. And an overall analysis appeared that the cutoff for this recovery was about 55 years. But when they looked specifically at selenium status, and particularly in a multivariable analysis, the selenium status was not an important independent factor. So to conclude this section, the recovery of thyroid function in subclinical hypothyroidism depends on age and sex, but not on selenium status. The fourth section then looks at thyroid and pregnancy, and I have a paper on that gives a detailed analysis of thyrotoxicosis in the first trimester of pregnancy. What happens when with patients who are known to have hyperthyroidism preconception and then outcomes in pregnancy, as well as a paper on thyroid autoimmunity and fertility outcomes in women undergoing assisted reproductive therapies. So the first paper is a paper from China looking at 125 women who present in the first trimester of pregnancy with thyrotoxicosis. And so 78 of them had gestational transient thyrotoxicosis, 26 had untreated Graves' disease, and 21 had treated Graves' disease, and 246 matched controls were also included. And the first thing they looked at was at the birth weight of the offspring. And you can see that patients who had untreated Graves' disease were significantly more likely to have reduced birth rate when compared with controls, as well as compared with patients with normal thyroid function. When Graves' disease was treated, this did not appear to affect birth rate. They also looked at a number of other outcomes, and you can see that premature delivery was true even when Graves' disease was treated. So this was still present even after adequate treatment of Graves' disease, but was most pronounced in untreated Graves' disease. And again, gestational hypertension was much more likely with untreated Graves' disease. For the first time, what this paper highlighted was that gestational transient thyrotoxicosis was associated with increased risk of gestational diabetes mellitus. And that those patients who had positive antibodies either to the TSH receptor or positive DPO were significantly more likely to have adverse outcomes. This was a study, again, using that same UK CPRD. So this is a GP database, was a population-based cohort study. 4,712 women aged between 15 and 45 who were hyperthyroid and then had a subsequent pregnancy between 2000 and 2017. And you can see that disappointingly only in 53% of these patients TSH was measured during pregnancy, and a suboptimal thyroid status was present nearly in about 30% of these patients. So this was defined either as a serum TSH that was greater than 4 or a low TSH with a raised free T4. The odds ratio of suboptimal thyroid status, so it was much more likely that those women who had definitive treatment were much more likely to have suboptimal thyroid status during pregnancy. You can see that over the years of the study, the amount of thyroid surgery that was undertaken went down. So this is before pregnancy. And similarly, the amount of radioactive iodine also over the years declined. Surprisingly, there was a fair bit of carbimazole use during the time period, and that certainly increased in more recent years. And a number of these patients also were treated with both drugs. But what was highlighted by the study here, that at any time in pregnancy, so when you look at the first and the second or third trimester, those patients who had radioiodine therapy or thyroidectomy were much more likely to have abnormal thyroid function or have a non-measurement of serum TSH. And it is therefore urged by this paper that better thyroid monitoring and preconception counseling of these patients is needed. And then finally, I'd like to highlight a paper on thyroid autoimmunity and assisted conception. This was a retrospective cohort study in China between 2015 and 2019 and included 5,400 euthyroid women undergoing assisted reproductive therapies, either with fresh embryo transfer or with frozen embryo transfer. 980 of these women had positive thyroid antibodies, either TPO or thyroglobulin or both. And what you can see here is that in these fertility and pregnancy outcomes, there was no difference between women who had positive antibodies compared to those who did not. And that was true both for women who were undergoing fresh egg transfer or frozen egg transfer. So it did appear in this retrospective study that autoimmunity did not affect these outcomes. So to conclude this section, gestational transient thyrotoxicosis does not affect birth rate and pregnancy outcomes, but there is a signal from the one study that I've shown that it may be associated with an increased risk of gestational diabetes. The control of thyroid function was worse in women previously given definitive treatment for hyperthyroidism, and thyroid autoimmunity was not associated with worse ART outcomes. So the fifth section looks at thyroid nodules, and I would like to highlight two papers here. The detection of malignancy in indeterminate thyroid nodules investigated with molecular testing, as well as comparing microwave and RFA ablation for benign thyroid nodules. So looking at the indeterminate thyroid nodules first, so this was a follow-up study, a US study between 2017 and 2019. It was prospective follow-up of a single center RCT that compared Afirma testing versus ThyroSeq testing. As you know, those are the two main platforms used for molecular testing in indeterminate nodules. What the study aimed to do was to determine the rate of delayed surgery and false negative rates in those that were Bethesda 3 and Bethesda 4. And those with negative molecular tests were followed up with ultrasound. You can see that compared with all nodules that were included, those that had a benign or negative test result had a similar range sort of gender distribution, similar nodule size, and similar proportion of Bethesda 3 and Bethesda 4 nodules. And so out of all the negative nodules that were tested, you can see that 162 of them underwent surveillance. What these numbers here reflect are the Bethesda 3 and the Bethesda 4. So a significant number of them underwent surveillance. The vast majority, 84% of them, had a stable nodule size. A repeat FNA was repeated in 50 of these nodules, and cancer was detected only in one of these nodules, so in 0.5% of those nodules that were deemed benign, either on a FIRMA or a Thyroid-seq test, indicating that fewer than 1% of those cytologically indeterminate nodules that were determined through molecular tests are cancerous on ultrasound follow-up over 3 years. And then I think increasingly we are now using thermal ablation techniques for benign thyroid nodules. So this was a systematic review and meta-analysis looking at microwave ablation versus radiofrequency ablation. And indeed, I often have patients ask me which one is better. It included 9 studies and 2,700 thyroid nodules. And what this first forest plot here indicates is the volume reduction at different months following treatment. But you can see that RFA was favored at 6 and 12 months in giving better volume reduction when compared to microwave ablation. Looking at symptom score, this was not different at any time point during follow-up between microwave ablation and radiofrequency ablation. And similarly, the study highlighted that complication rates are very low, and again, that there was no difference between RFA and microwave ablation. So to conclude the fifth part, and we're nearly there with the pie chart, molecular testing is accurate in ruling out cancer in indeterminate thyroid nodules, and radiofrequency ablation appears to be superior to microwave ablation in terms of volume reduction at 6 and 12 months, with a similar safety as well as cosmetic and symptom score profile. And then finally, I have 2 papers I would like to highlight on thyroid cancer. One focuses on the use of GLP-1 agonists and the risk of thyroid cancer, as well as on excellent response differentiated thyroid cancer. So the first one was a nested case control analysis of the French national database, which included 3.7 million patients with type 2 diabetes who were treated with second-line anti-diabetic treatment between 2006 and 2018. What the authors did was highlighted all cancers identified between 2014 and 2018, and there were 2,562 cases of thyroid cancer and 45,184 matched controls, matched for age, sex, and duration of type 2 diabetes mellitus. So you can see that both for all thyroid cancers and for medullary thyroid cancer, the use of GLP-1 for more than 1 year was associated with an increase of any type of thyroid cancer with an odds hazard ratio here of 1.58. And when this was used for more than 3 years, the hazard ratio was 1.36. And medullary thyroid cancer, again, for a median time use of between 1 and 3 years, was significantly higher. That, of course, is a little bit of a problem, since many of the tabloids tell us that indeed we have now found in these GLP-1 analogs a miracle cure. Importantly, though, in interpreting these results, we have to bear in mind that thyroid disease was significantly more common. So this is benign thyroid disease, either goiter, hypo, or hyperthyroidism, was significantly more likely in the cases when compared with controls, and that the thyroidectomy with benign findings was not more common in GLP-1 users. So I think there's been a very significant detection bias here, and indeed patients on GLP-1 analogues probably visit endocrinologists who are much more likely to perform ultrasound imaging. A further thing to note was that MTC accounted for 15% of all thyroid cancers, and that is certainly not the distribution we see in the general spread of thyroid cancers, and therefore maybe the definition overestimated it. But I'm highlighting this paper because there have been since at least 6 commentaries that urge caution, both in interpreting results, but also in the use of GLP-1 analogues. So it is possible that they cause a small increase in thyroid cancer, but I think we need further data to ensure that this is not detection bias. We need to balance multiple benefits of these GLP-1 analogs, and for some patients, the benefits will outweigh the risks. And then my final paper is a retrospective cohort study performed in Poland, 1998 to 2021. It included 2,302 patients with excellent response on dynamic risk stratification, and you can see that reassuringly recurrence rates were very low, 1.4%. You can see that the recurrence rates were higher in patients who had follicular, poorly differentiated or oncocytic cancers. And on multivariate analysis, it was more common in younger patients, those who had larger tumors, lymph node metastases, and incomplete resection, those who had a postoperative higher ATA risk score, and those patients that required treatment with radioactive iodine. So most of the recurrences occurred within the first 5 years of the start of observation. And so this graph here illustrates what the table illustrated, is that the recurrence was lowest in papillary cancer, but with these other types, follicular cancer, poorly differentiated cancer, and oncocytic carcinoma, recurrence was significantly higher. Specifically looking at PTCs then, those patients who had an N1 histology were significantly more likely to recur. The most effective method for detecting recurrence was ultrasound and finely for local recurrence, and to detect distant metastases, FDG PET was highlighted as an important investigation. But what the authors conclude is that DTC patients with N1 disease, or those with those more adverse histological subtypes, will require longer follow-up. So to conclude the final section of this talk, GLP-1 agonist may be associated with an increased risk of DTC and MTC. Recurrence in excellent response, DTC, is very low, but there are certain specific histological subtypes, and those patients with N1 disease who should remain under longer follow-up. Thank you very much.